So when we see patients and we're trying to determine the best treatment plan for them, as an oncologist, we tend to focus on the evidence, what's the best cancer drug. But our patients are far more complex than that. We need to think about the entire patient. So when we're thinking about and evaluating the risk, what are some of the morbidities or comorbidities they may have? So they may come to us with a history of hypertension, diabetes, dyslipidemia, and what is the impact of that in terms of their overall cardiovascular risk when they're treating them with cancer drugs? So at our talk that we have at San Antonio this year, we're going to talk about risk assessment, baseline risk assessment. So when patients come into your clinic, how do you assess their baseline risk of cardiovascular toxicity? And fortunately, we have a new guideline that just came out in August of this year, put out by the European Society of Cardiology in collaboration with the International Cardio-oncology Society, that shows you or explains how you determine baseline risk. And once you've determined that baseline risk, what are some of the prevention strategies that you can use to really proactively treat patients? And that may be a simple thing like treating their hypertension. You wouldn't believe how many people come to my clinic and their blood pressure is not well controlled. So what is the impact of uncontrolled hypertension when then you're giving them a cancer drug that may make that hypertension worse? So it's all about that baseline risk assessment that we're really trying to emphasize with oncologists and cancer providers, is that we need to understand that before we start their cancer treatment, rather than waiting until they develop a cardiac issue or cardiovascular toxicity and then trying to deal with it. So some of the challenges that we face, obviously, as newer breast cancer drugs come into the clinic, we need to have a good understanding of their impact on cardiovascular health of patients, and so that is going to take ongoing research. But importantly, when patients come into our clinic, we have to understand not only what is their baseline cardiovascular risk, but who is going to help us manage that risk. And so that speaks to a collaborative approach in the care of our patients. So we can't expect oncologists to do everything. We're already taking care of their cancer. We need to work with the primary care providers very closely, and cardiologists, and maybe even exercise physiologists and our pharmacists, to determine if this patient's coming into my clinic and they have uncontrolled hypertension, can I contact the primary care provider? Can they help me manage that comorbidity? What about if they come and they already have cardiovascular disease? Can I ask my cardiologist to help me manage that? Can they modify their medications so that I don't make their cardiovascular disease worse by treating them with what I consider the best cancer therapy? So that's where the whole idea of cardio-oncology was born. It's been now around for about 15 years. It really speaks to that collaborative approach, that holistic approach, looking at the entire person, not just this person has cancer, but this person has cancer and they come with other issues, right? Lifestyle, smoking, they don't exercise, maybe they're a bit overweight, comorbidities. How do we manage that whole package? And it's something that we have to look towards working together with our colleagues to do that, because at the end of the day, even if we get patients through their cancer therapy, what is their survivorship going to look like? What will happen after they're finished, complete their treatment? So, when someone was diagnosed with breast cancer, survivorship starts day one, and we treat them with the best therapy. But our mission, I think, is not just to treat their cancer, but to treat them so that they have, a life that's long and fruitful and meaningful and good quality of life. The one thing we don't want to do is actually make them worse off in terms of cardiovascular health. And now there's some literature actually stating that postmenopausal women, 7 years after their breast cancer diagnosis, are at higher risk of dying of cardiovascular disease than they are of breast cancer. So we're doing a great job in breast cancer treatment, but we need to do a better job at managing the rest of the individual and their comorbidities and so on, and managing that with our colleagues.